Welcome back to the American College of Surgeons Bulletin Brief from the front line, Surgeons' Voices. And with me today is a group of people to discuss the recently held Educational Summit. So we have a little different format with this interview, and I'm going to start out by introducing our Director of Education, Ajit Sachdeva, and my partner in the Board of Regents, the Chair of the Board of Regents, Dr. Scott Levin. Why don't we start, just Satch, tell us why everybody's here today. Why do we have everybody here with us today on this video?
Thanks so much, Steve, and it's a real privilege to join the group and to speak with you about our recent Education Summit. Approximately 7 years ago, Dave Hoyt, our executive director, and I were talking about how we might get the House of Surgery together to discuss an important topic each year. And we embarked on that effort with the support of Dr. J. David Richardson, who was then in the leadership of the college. And we pulled together a summit, and we invited the leaders from across the House of Surgery, from the various certifying boards, review committees, academies, and the program director organizations. And over the years, each time we have selected a very pertinent and timely topic, and the summits have been a huge success. This year, we selected the topic of resident selection, and all of us, regardless of our surgical specialty and field, know that the selection of residents has been a challenge. And we've had major concerns about people coming into our residency programs at the right level of training and with the right skill set. Also, more recently, there has been greater concern because of the impact of the COVID-19 pandemic, what it did to virtual interviewing, the disruption in the selection process, and of course, the recent national changes, such as doing away with USMLE Step 1 scores. Now, those scores even historically had limited relevance to the performance of our residents, but clearly we lack objectivity quite often in selecting our residents. And also we need to look at the holistic approach to basically selecting them and basically then incorporating them into our residency programs. So with that in mind, we selected this topic, and I will turn it over to Dr. Levin to pick up on that theme and build further.
Thanks, Satch. It's an honor to be here with distinguished colleagues. As we've written in the bulletin brief, and I want all of our members to know, the role of the College of Surgeons is multiple. In education, in advocacy, in quality and patient safety, but time doesn't permit me to go into all the wonderful things our college does. I do want to recognize Dr. Sachdeva, the encouragement of our executive director, David Hoyt, and particularly our past president, J. David Richardson, who thought that the college should have a role in convening all members of the House of Surgery on topics related to education. And it couldn't have been a more wonderful convocation and meeting a week or so ago when colorectal, plastic surgery, cardiac surgery, thoracic, ophthalmology, I mean, you name it. Steve, the entire House of Surgery came together. And what we've been trying to do is not only through your outstanding efforts of communicating to our fellows the power and the efforts of the college in multiple directions, but this year really make it the year of specialty engagement with our regents, with our governors, with our advisory council. And this is a prime example. Satch, I'm looking at you on the screen. A prime example of how the entire House of Surgery came together to get work done on what? On behalf of education. And I will say credit to you, our annual clinical congress, our program. There's a lot of content there, and correct me if I'm wrong, the 55% of the 100% of our members come to our clinical congress for education. But now we've broadened the definition of education in the college, working with all the specialty boards, looking at resident selection. How do we do it virtually? How do we matriculate our residents in the era of COVID? And what's going to change and be the silver lining? We talked, for example, about the decreased costs to our students, right, who are already in debt, to optimize a virtual platform of interviewing and making the selection. And all of our institutions, whether it's the private sector or academic medical centers now, recently this past year, for example, I ran a search for a major department chair, all virtually, until the final visit to campus. So we had a very fruitful discussion on how to do this. And we have, distinguished educators on, and I want to do ladies first. First of all, from MedStar in Georgetown, Sonia Malexide, who will certainly comment, then Celia Davino, and then my friend across town, Jerry Eisenberg, who's the vice chair of education and surgery at Jefferson, a distinguished colorectal surgeon. We should go around the room and ask them. I mean, Sonia, Celia, and Jerry, general surgery based, for example, but this was a convening on common problems that we all face. And I've always said it as a specialist, our DNA is about 99.5% the same. The other 0.5% is, putting pipe into a distal coronary, or Celia sewing in a hepatic vein, and Sonia and Jerry, you doing a bowel anastomosis, and me doing microvascular surgery. Our DNA is basically the same. And when it comes to education, now, Satch, in the broad definition of modern education, we're all in the same boat. We're all facing the same problems. And for me personally, last comment, Steve, this year, reaching for specialty engagement. We really wanted to bring the House of Surgery together. This, Satch, and we'll pass on to Dr. Richardson, was a prime example of monumental advances in that one thing facilitated by the college and your leadership. So, Steve, maybe Sonia can comment on what she saw, what she learned, and then Celia, and then Jerry.
Yeah, I think that's a very good way to do it. And the point you made about the House of Surgery is key. The ACS is the House of Surgery, and it's great that this was an interdisciplinary meeting. So we can start with Dr. Malexide, certainly.
Thank you very much. And thank you for inviting me to be a part of this discussion today. I'm an otolaryngologist, first of all, Dr. Levin, so I haven't done a bowel anastomosis. It's been 20 years when I was a general surgery resident back in the day, but very grateful to be included as one of the subspecialties. And I agree, we're at the House of Surgery, and otolaryngology is very happy to be within this group. I agree, there's so many challenges for the residents these days and the entire application recruitment selection process. I'm particularly interested in the application side of this. There are challenges for not just our students, but for our programs, our residency programs, our academic institutions. And I think there's so many opportunities for us to improve this process. Again, not just within each of our specialties, but if we come together as a group within the House of Surgery, just to alleviate all the challenges for the students and for the programs. We do need to, I think, involve our stakeholder partners, ERAS, the AAMC, as well as NRMP in this conversation, because I think we can all agree we can improve this process significantly. We know application numbers are rising tremendously, not just within otolaryngology, but all the other subspecialties as well. And it's become this arms race, if you will, for our applicants, our students. And some specialties are receiving 70 plus applications per student, which is just crazy. The cost and the inequity that, you can just imagine how that expands across, all the students. So one of the things I'm interested in is signaling. This is preference signaling as a program that we instituted in otolaryngology this year. It was very well received by our specialty. We implemented it, and it was very successful. And we have some great data. We're working with ERAS and AAMC to show that the applicants did actually get interviews at the areas that in the programs that they signaled. So it was effective in improving that process for them. And also we have some data showing that this might actually improve diversity and equity. So we're excited to roll some of that information out in the coming weeks. And my hope would be that, again, we'll all come together as surgeons to implement this program and other programs. We can look at application caps, interview caps, or many other ways to improve the process. But I think we need us together collectively, the ACS, certainly the gorilla in the room, to help us move some of these initiatives forward. So thank you. I'll stop there.
I appreciate those insights. And Dr. Davino, you're coming at it from a different point of view, running an interdisciplinary team to begin with, because you've got the Department of Surgery there at Mount Sinai. So how did you feel we accomplished our mission at the college of getting people together, different stakeholders, speaking a common language to improve outcomes in resident selection in all disciplines throughout the country?
As everybody has said, the last symposium or the last meeting we had with this group was really a tremendous success, in that I think Dr. Levin put it very simply. The ACS now really plays a very major role in what we call the House of Surgery as a convener for all the other subspecialties that share the same challenges that we do in general surgery. I come into this from a standpoint of a program director and a vice chair for education. So I also oversee not only residents, but also the fellowships, and as well as working with Dr. Sajiva as the current chair of the Committee on Resident Education. I think it is very important to address this issue. It's been highlighted by the challenges we have with COVID, but the problems existed before that and probably will need a lot more of innovative solutions. The concept of choosing the right resident and the right personality for a specialty, whether it's general surgery or otolaryngology or orthopedics, is quite a challenge. Whatever you say, whatever metrics have been available aren't foolproof. So my charge during this meeting was to look at the current interview process, and it has, the landscape has really opened up this whole area. Because of the existence of the virtual nature, it has leveled up the playing field for everybody in terms of cost, perhaps in terms of the diversity of the applicants. However, it comes with its own set of challenges as well. And I think that's still something that we need to address, because there are certain things that cannot be addressed by a virtual interview that sometimes you need to have an in-person, interview. So we discussed at length, how should interviews be conducted moving forward? And once you've open the door to a virtual interview, it's hard to go back. We also address the issue of who should we be interviewing, whether you are interviewing for a neurosurgeon or you're interviewing for an orthopedic surgeon. Basic core values are very, very similar across the board. And, there are innovative ways of screening applicants, and those really need to be explored. And the third, and I think Sonia addressed it, is the importance of increasing diversity at all levels. And I think this can be addressed if you start from the core values as well as what the institution stands for. We don't have a panacea for who to interview, how to interview, and how to choose. It's a long process, but I think we came to the conclusion that there are there's so much common ground between specialties. And I think perhaps a multi-specialty survey should be done across specialties to see where we have common ground and start from there, so there can be some form of a guide is not the right word, but a possibly some basic principles that will help us make the right decision.
Thank you very much. Jerry, you're representing colorectal surgery, but also in your role at Jefferson, a lot more in the educational spectrum. So what do you think we're going to be able to bring forward from what was discussed during this last educational summit? What's going to be version 2.0? What are we going to work on, and how are we going to assess the progress made?
So first of all, I want to congratulate the college on bringing together a group of educators, because anytime you do that, there's such excitement and momentum. But then to have the foresight to have cross-fertilization with all the specialties just makes it that much more meaningful and vibrant. So the discussion was really powerful. The group that I was involved in, we really looked at the idea of a skill set. And should the incoming resident have a certain amount of skills, and should that be tested prior to their entry into the residency? I mean, it's really an interesting idea, and a few places have kind of dabbled in that, but I don't think we really have the answer yet as to should we look at just technical skills, or should we look at professionalism issues also, ethics and empathy and communication skills. And I think these are all things that we may have come up with more questions than answers, but I think we're entering the era where we have to really look at this. And there are some centers even internationally that are starting to study these concepts. And probably, I would say within the next 5 to 10 years, we will have some ability to test some of these skills and make a more meaningful selection of the resident that we want.
During our educational summit, the concept of grit was brought up, and Angela Duckworth is a Penn psychology professor who I know quite well. And, the grit scale and the perseverance. So Celia, it's 3 a.m. You've taken down the anastomosis 4 times. You want to be comforted by that resident or fellow who's going to be right there with you, as opposed to somebody who caves or, can't handle the pressure and so forth. And you know what we're talking about. So to Celia and Sonia and Jerry, and then Steve, what about the grit scale? What about measuring just, that young person's going to be in the foxhole with his colleagues or her colleagues, is going to be in the middle of the night, despite the 80-hour work week. Those are important things. And I mentioned it during the summit, educating residents for 30 years. I'd rather have grit than board scores. This is Scott Levin talking, because, to get to applying to a residency, you've gone through medical school, you've gone through college, you have, fairly intelligent pool, but I'm interested in grit. What do the people on the call think about grit?
I agree with you 100%.
Pardon?
I said, I agree with you 100%. I think that is such an important quality, the resilience, the grit, all of those. Also some of the professionalism metrics, which are hard to identify. How do we find those characteristics in these residents? I know general surgeon, Dr. Sachdeva, you may speak to this a little bit. There's been some situational judgment testing. There's some personality testings that some other specialties have dabbled in, but I'm not sure that we've actually found the right way to measure that. And I would be very interested, and I think we would all be very interested in, being able to push that forward. Yeah, we can teach with the knowledge. Yes, everyone is smart. We can certainly teach skills to the majority of the residents. It's how do you identify the people. It's inherent. You're born with this. You can't teach the grit and the resilience. And how do we identify them?
I'm very excited that you brought this up, because we actually studied grit in our one class of medical students and tried to look at the differences between, we'll say, technical and non-technical specialties that they were going into. And although we have a large class of 265, when you break it down into each of the specialties, it gets harder to have really accurate or valid numbers. But we did show a trend towards surgical specialty students having a higher grit scale, according to Duckworth's work. But I would add to your grit question in the middle of the night, I also want someone who can communicate clearly. And I think that is a critical thing that we need to measure.
You know, I'll just say, Steve, that I think the survey idea is brilliant, you know, to the specialties. I think we're on a path, Satch, to sort of go in a certain direction to improve our process, not throw everything out. You know, we talked about the value of the handshake. Somebody comes into your office for 5 minutes, sits down. You know, most of us have seen thousands of patients. You can size up a patient, their emotional intelligence or cultural background. That's always helped me when I interview, but I don't get it right. I don't always get it right. And, you know, we have 800 for Penn Ortho. We interview 80, we select 8. And I can tell you there are individuals that struggle. So we didn't get it right. Okay, we're there to support them. We have the ACGME, we have all sorts of support. That's not the point. But I personally don't always get it right. I've been doing it a long time. So to revamp, to look at new opportunities through the college, doing all the things we're talking about, I'm very enthusiastic about that, Satch.
I think these are all very good points. And we always talk about a holistic approach in choosing our house staff. The challenge with that is, what exactly is the holistic approach? Is it looking at the personality? We looked at the background. There are multiple studies that show success rate inversely proportional to the board scores, the age and the experience. I'm sure there are many different iterations of that. We discussed it in our group, Scott, about you want a person who has hand-eye coordination. You want a person who has played a sport so that they have a goal of excellence, and at the same time being able to play with a team. But at the same token, what about that violinist who really has the same grit and determination to be, you know, to play at, you know, a concert hall or something like that? So I think probably with all the brain power in this group of educators in the college, we can probably somehow identify some key points that may be a little bit more predictive than what we're doing right now, which are the STEP scores and the shelf scores.
Steve, back to you, closing remarks.
Yeah, all great commentary, and there's a lot of things that can't be measured the same way as knowledge of anatomy or physiology that have to do obviously with resilience, with grit, with empathy, with a lot of the other characteristics, the ability to work as a team, the ability to lead a team, you know, humility, all of these other attributes that are important. So Satch, I'm going to ask you to close, and I'm going to ask you by saying, what is version 2.0? I mean, what do we need to do next besides the mechanics of virtual versus the handshakes? What do we need to measure? What are we going to talk about the next time to go that next level to help everybody better pick their trainees?
Thanks, Steve. I think the summit gave us a lot of good information with the involvement of all the specialties, as we've talked about. And just prior to the summit, actually the week before, we had convened a committee, and Scott was present during that meeting as well, where we talked about defining what is it that can help in achieving success and excelling. And from all the comments that we've heard, it's very clear that people have to have a passion, and then they have to work hard to continually improve and reach those goals, which is what Angela Duckworth talked about in the GRIT publication, the passion and the perseverance piece. And then she linked it with Erickson's work on deliberate practice, etc. So we need somebody who has that drive to do that, plus all the other qualities we look for in a professional, the emotional intelligence and some of the things we've talked about. The next step would be then to figure out how we can get that information in our selection process. And we need to build on what has been published, look at the evidence where it might exist. It's very weak in many cases. A lot of it is anecdotal, where we have an opportunity to extend the boundaries. We also have the opportunity to reach out to industries and professions outside of surgery and medicine, whereby we can learn from some of the other people, and even the military. We've had very inspirational military speakers who have talked about some of this and leadership over a long time. We need to look at that piece of input as well. And then drill down to what tools we need to develop, if they don't exist, to measure those competencies in our incoming group of residents, and how we make up the gaps where we can make them up. So there's a lot of work to be done. And I think the summit has given us a lot of fodder to do that. We will certainly look at some sort of a publication coming out of this so we can share the information across the House of Surgery. And beyond that, more importantly, we need to get to work and to divvy up the work so that we can have various areas addressed along the lines that we've been talking about to reach that goal and to get the best people into our programs so that they can be the best surgeons they can be. Thanks.
Well, thank you, Sach. Thanks, everybody. Thanks, Scott, Sonia, Jerry, Celia. Thanks, everybody, for your time and your insights today. And you mentioned, Sach, the work to be done. And although we don't necessarily know in specific terms now what that work might be in 2 years, 5 years, we do know who's going to get it done. And that's the American College of Surgeons continuing to convene the House of Surgery, bringing everyone together to strategize, to talk, to figure out what is that work at that point in time, and then to get it done. So thanks, everyone.